Welcome to Assisted. I'm Chelsea Roff. Assisted dying is said to be a compassionate, caring choice.
But in this series, we explore why it's not that simple. I'm Fiona McKenzie, and we'll look at why assisted dying has such a big impact on women. I'm really pleased tonight that we're joined by two guests from Canada, Leonie Herx, who's a Professor of Palliative Medicine, and Ramona Coelho, who's a family physician and also member of the MAID Death Review Committee in Ontario. So both really knowledgeable on MAID in Canada. It's so urgent that we have you here because Canada has so many lessons for us, and we're doing a whole series of interviews with academics, people fighting MAID there, and families as well who've been affected by MAID. So I'm really honoured that you've given us the time, and I'm hoping you'll have just so many insights for people here as to how assisted dying could turn out. Because Canada, it's kind of like us. Like, we have such a shared history, we have shared language, lots of shared activism, and I think we have to learn the lessons, because people see the headlines from Canada here and think, whoa, we can't be like that.
I know you've both been very closely involved in Canada's assisted dying debate. You've testified to the Parliament in Canada on this. And of course, you both work directly with patients clinically. That is your work, your day-to-day life. I wondered if you could share a little bit about what first led you to speak about the risks of these laws in Canada.
So at the time that our Canadian law was being proposed, I was very actively involved in the Canadian Society of Palliative Medicine. And shortly after the law was enacted, I was the president of our specialty society. And so it was really important that we spoke up as a body of palliative medicine experts, because the proposal was that this was for people who were at their natural end of life, and there's a lot of misconceptions and myths about palliative care that were being perpetuated in the media, that natural dying and death was this horrible, painful process, that medications we give in palliative care to optimize symptoms already hasten people's deaths. And that there's really the only way to have a peaceful death is to have an assisted death. So there was so much impacting our day-to-day practice of palliative care that we needed to speak up about. And then there was also an assumption made, an open advocacy strategy, I would say, that this would be part of palliative care, because to normalize it, I really think that these are people already dying. They wanted to make it sound like it was this compassionate way to take care of people at the end of life. And so we had to really speak up and say, actually, this is opposite to the philosophy of palliative care, where we help people live well while they're dying. And our whole focus is to provide care and support to help people make the most of their final time. So we started speaking up very early about the distinctions between palliative care and MAID, and then also to say natural dying and death is not this horrible, terrible process. In fact, there's so much beauty and healing and hope that happens at the end of life, and we need to talk about that. So that's kind of how I got involved in the first place. Ramona?
Yeah, I'd say I got a lot later involved than Leonie. I take care of marginalized patients. I'm originally from Montreal, and I did home care of people who were dying in their homes from organ failure, or who had very severe disabilities or mental health addictions. And when I moved to London, Ontario, I attracted a similar group of patients who find themselves on the margins for different reasons. So the prison started sending me patients. A lot of refugees started coming to my clinic, and patients who live in low-income housing where I work. So a lot of people with severe disabilities and mental health addictions as well. And initially, when this legislation was proposed, I was distressed because I take care of patients who have death wishes, different from Leonie, caused by life suffering. They're not necessarily always at the end of life, but they can be very desperate and they can be begging to die. And part of me learning to be a physician and growing with my patient population was realizing recovery and hope is possible. Even in the face of death, there can be, as Leonie said, recovery and closure and all these beautiful things. And I would say that myself, initially, when I started practicing, I was deeply scared by the suffering that I saw myself. I actually understand this gut reaction, let's just end it all now. Want this to go away because it's never going to get better. And then I actually learned through my practice that no, people get better. Actually, it's a kind of therapeutic nihilism to think that there's nothing that can be done here to remediate and help people through the suffering process. But I'm not a palliative care doctor, so when this legislation was introduced, I kind of thought, I'll keep my head down and I'll just protect my patients, and I'll make sure that I fight for conscience rights because there was already talk about how this was going to be in the medical system, that we'd all have to participate somehow or put patients on a pathway if they wanted it. But that was my focus. When our Canadian law expanded outside the end-of-life context, then I realized all of my patients are wanting death and now have a legitimized form to access that pathway before they can get care. So my patients can take months to a year or 2 years to get subspecialized therapy that they need. Often they're refused full disability supports or home care that they need to function, and yet they can access medical assistance in dying. I would say relatively easy where I practice. The average access time is 3 days to access a MAID assessor in Canada. I've had patients who've been refused disability support. We live in a socialized healthcare system, just like the United Kingdom. And so they refused their disability support program, but they've been approved for MAID. And that kind of desperation is what drove me to get involved on a political level, to try to help members of parliament see the dangers that they're placing patients in.
One of the things that perhaps we are learning from Canada, because lots of people here are saying we never want to be in the situation where people are finding it easier to access assisted death than palliative care or room in a domestic abuse refuge, or support to deal with their disability, or better treatment for a condition which might respond well. I mean, all of that, we must make sure that's available. And it's so chilling to hear that that's happened. Just this one question. What are you seeing from politicians? Are they thinking, gosh, we need to put the brakes on when they hear this from you? Or
the current government, I would say, has continued to have a very strong agenda around this should be a right that anyone with any type of suffering should be able to access. And we've seen that in their progressive expansion of the legislation from what started off as a reasonably foreseeable death, which was in and of itself problematic, to anyone with a chronic illness or disability. And then they continue to push for it to be expanded to people with mental illness as a sole diagnosis. The government also continues to want to expand it to full advance requests, where you could make a request for MAID, euthanasia, assisted suicide, many years in advance of a condition that may end up then causing you to lose capacity, for example, dementia. That's currently there's an engagement survey by the government currently right now underway in Canada to look at expanding to that. In one province, Quebec has already done that, and there continues to be advocacy around expanding to children deemed capable to consent to healthcare decisions. So I think the Canadian government has been very clear and persistent since 2016 that this needs to continue to be made available to anyone that deems their suffering to be intolerable for any reason. Ramona, what are your thoughts?
Yeah, I tend to agree with Leonie, especially the evidence is there. I would say that our Liberal government was very much in bed with Dying with Dignity, which I think is very similar. They're all part of this parent group, this World Federation of Right to Die, I think. So there's a UK partner that you guys have, but Dying with Dignity here in Canada is one of the wealthiest lobby groups and has been given charitable status. I have many meetings with the government every year. There was an article that came out called the lobby group that owns the conversation around assisted dying. I would look that title up and read it. It's very telling about how powerful stakeholder lobbying by very wealthy, privileged people has painted assisted dying as something very compassionate and has really spoken over the disability groups, the mental health organizations, all the people that are concerned about vulnerable people, Indigenous leaders. And so you have this very powerful lobby group that has really dictated what the government has done. I think behind closed doors, when I started doing this, I really did, I don't know if this is what you do in the UK, but when you have an issue, you sit down with your local member of parliament. So that's what I did. He was stunned. He was upset and stunned. And then I met with somebody from the other party, also stunned. And that's how I kept getting involved. And so I think most of the members of parliament didn't actually understand what they were signing on to. But there's a lot of potential to lose face here because this is a human rights violation. The UN, we have 3 experts. We have our Human Rights Commissioner of Canada. We have many social justice and disability organizations who have condemned our assisted dying regime in Canada as infringing on the rights of people who are are poor, who are elderly, who are disabled, are most marginalized. And so I think the government has a lot to lose face now in terms of turning back. And that's part of what's leading to them just kind of like walking ahead, not wanting to walk back. But I do think that they keep pushing back MAID for mental illness. MAID for mental illness as a sole condition was supposed to start in 2023, I think. Then it was extended to 2024, and now it's been pushed back to 2027, which I think shows that they keep saying, oh, the provinces are not ready, that's why we're not doing it. But really, I think that they're starting to understand what they're doing, and they're trying to figure out how to not lose face.
I hear so many echoes of the moment that we are in the UK right at this moment. It feels like you've been through it and you're describing the reality that's unfolding here. Yeah, here in the UK, we often hear, again, Canada written off as a completely different law, completely different system. It would never happen here. So I know that in Canada, it was first legalized only in these extreme cases. I mean, extreme, but in people who their death was already foreseeable. They were, quote, dying already is what we always hear. I wonder how quickly did that change?
You're right. I think the way it was sold to Canadians and in Parliament was that it would be a very strict law, only used for very exceptional circumstances. I think in Quebec, they had predicted like maybe 100 cases in the first year, and very quickly it became much more than that, obviously. And within months of the legislation being enacted, there were court challenges for people who were not approved for MAID, who said, this is discriminating against my right to access assisted suicide and euthanasia because my death is not considered foreseeable. There's a case in Ontario that went to the Superior Court, case AB, and it was a 77-year-old woman with osteoarthritis who said that she should have a right to access MAID and that she didn't have a progressive life-limiting condition. And so the judge ruled in that case that a reasonably foreseeable death did not require any specific prognosis, and that her death could be foreseeable based on age alone because she was 77 years. And so she was approved for an assisted death. And very quickly after that, a prominent MAID provider in Canada, Dr. Ellen Wiebe, publicly was interviewed by the Canadian Broadcasting Company and said how she was now going to go back and approve people she had previously denied from MAID, including a woman, Robin Monroe, that was had Parkinson's disease and had been denied access to MAID because her death was deemed not foreseeable. I think her prognosis was 8 to 10 years. And so in the media, that we have evidence of very clear changes in the way MAID providers were practicing and interpreting the law based on these individual cases that went forward.
Health Canada had originally said that this would be something that would be highly regulated. There would be safeguards to prevent wrongful deaths. And very quickly, the language switched from safeguards became discriminatory, limiting access, barriers to exceptional care, which all of a sudden became, instead of an exceptional procedure, it is an exception to the criminal code for culpable homicide, all of a sudden it started to be talked about more as this is actual care. And this is almost like a human right. And then you have in Quebec another case that said it was discriminatory to have reasonably foreseeable natural death as a criterion. And so without further study, our government in 2021, they didn't appeal that court case, that Truchon-Gladue court case. They decided to move forward and expand medical assistance in dying into 2 tracks. So track 1, initially for reasonably foreseeable death, they dropped a lot of the safeguards to prioritize access. And 2, they opened up that new pathway for people who are not dying with a whole set of different eligibility criteria. But the language of, a strictly regulated procedure for people who are suffering became very, very much replaced in the media by we are denying access and people's right to die. And that language quickly led to this kind of blowing out open.
And as Ramona said, the government removed safeguards that were initially put in place to reduce the risk of wrongful death and premature death. So including a reflection period, there was originally a requirement for 10 days, time from when you made the written request for assisted suicide to when it was received. The requirement for 2 witnesses who were supposed to verify that this person was making a free request and that person could not be a healthcare provider. They changed that to 1 witness and it could be a healthcare provider and no 10-day waiting period. So you could technically get MAID on the same day you requested it. And in fact, I have seen that, and I've seen it very commonly within 1 to 2 days. And they also removed the requirement for a person to reconsent for MAID just before the lethal injection procedure. So a person could now lose capacity and enter into a verbal agreement with the assisted suicide provider that if they no longer could consent, that they could go ahead with it anyway. So those are just a few things that they removed. And the reason they said that is because they were not effective safeguards, and they were actually barriers, as Ramona said, barriers to accessing MAID, and were causing unnecessary hindrances in people being able to access this right, which was, as you say, portrayed very much as good health care and the only way to die with dignity. That was the type of language that we get in the Canadian media, this very romantic notion, and couples getting assisted suicide euthanasia at the same time so that they can, die together, and they were together in life and now they're together in death. Like, these are the kinds of way that the popular media and the culture shifted over time to really glamorizing this.
On that point you said about safeguards becoming barriers, I want to just read you this passage. These are the people who are responsible for operating assisted dying in Victoria and one of the other Australian states, and they told MPs in Parliament last week that the gag clause, so doctors not being able to talk about this with patients to bring it up, and the waiting period, as you described, are up for challenge. They have been shown not to be safeguards, but in fact impediments and barriers to equitable and compassionate access to this scheme. And then the other doctor said, they seem like a good idea, but they do tend to be barriers more than safeguards.
Exactly the situation that happened in Canada. I think that speaks to those lobby groups it's an international network, actually, Dying with Dignity, Compassion and Choices, and they've really looked at how to move this forward across the world successfully and use the same strategies internationally. It's very powerful.
Yeah, and I think that what's being lost in the public debate, and very strategically in the United Kingdom, not having Canadian witnesses, not having people who have concerns, you're losing the concerns that assisted dying can become the path of least resistance. Actually, a path of people who feel not wanted, people who feel lonely, people whose needs are not met. There are cases of dual euthanasia here where really undue influence of one partner has been documented. So, for example, if you look at our Health Canada report, the reasons that people are choosing MAID, even in the end-of-life context, largely loneliness, feeling a burden, existential fear of the future. These are not exercises of choice and autonomy. This is not about access to something that is my right. This is I don't feel like I'm worthy to be alive. I don't feel like people are making my life worth living. I don't feel people care about me. And that is not a program that enables choice. It is a program that silences people, because once they're dead, what can they say? That silences people who had their needs unmet, that our society failed to love enough.
I know Fiona will have an excellent question for you around couples being given assisted dying, but I just want to draw one more parallel, especially for those listening in the UK, to, you talked about the law being challenged on this notion that it was depriving people of rights, and that you can't grant access if assisted dying is seen as a medical treatment, and you say, well, we're only going to allow this medical treatment for some people, but not others, it really sets it up for court challenges. And there was an amendment that came through this week from the sponsor of the bill that changes the language around. There's an exclusion currently in the bill for that you can't be found to be terminally ill only on the basis of a mental disorder or disability, but it's now changed. It's proposed to be changed to only because they are a person with a disability or mental disorder. And it really set off alarm bells to me. I'm like, well, that really does sound like it would be well placed for a challenge in court, that you're somehow discriminating against people with disabilities or mental disorders.
Yeah, I mean, I've spoken about this in Canadian Parliament, that the whole kind of framing of assisted dying as medical is not correct, right? Medicine is about proportionality. It is about you don't give a huge treatment that is going to cause other harms unless the benefits are really there. And medical assistance in dying, regardless how people talk about it, we're ending suffering. No, you're actually ending life. You actually didn't target the suffering. When Leonie does palliative care, she is using her amazing skills to end suffering. When I help people find social means to answer their life suffering, I'm using my clinical skills and my medical skills to try to end suffering. MAID is ending the person. So in terms of proportionality, it doesn't fit at all with the principles of medicine. It's not healing. It's not about recovery. It's not been studied. We don't know a lot about it. Because how can you? How can you study? How can you know from people who have died what the experience was like? We don't know. And placing it in medicine is extremely dangerous. And yet MAID is like wanting to play both teams. It wants to be a medical procedure for the respectability of having physicians and clinicians involved. And even though actually it is just an exemption to the criminal code, but it's argued like medicine for its further expansion. And I find that really ridiculous. It's contradictory in all of its principles.
Well, yes, and in the Canadian context, you don't have to have actually received any care for a potentially treatable condition. You only just have to be informed about what your possible options are. Those options don't even have to be accessible. And so, I've had patients who couldn't actually stay in their home communities and get access to hospice or home palliative care. And the only thing available in their communities was someone who would provide assisted suicide to them. So, how is that an autonomous choice? So you can be told, well, you can have this and this and this, but then it's not actually available. So, and it, as Ramona can speak very well to, for people that have chronic illnesses and disabilities, like access to specialist care for chronic pain, to get equipment, to, a ramp to get into your home, these things can take months or years even to get put in place. And so it's really like a fast track to assisted death rather than supports to help people live well, because it can be provided very quickly. And what's also been happening in Canada is, even though there's these two tracks for people who are not with a foreseeable death, there's been teaching coming from, and I would call them the MAID activists. And so we have this Canadian Association of MAID Assessors and Providers, which is really, I would say an activist group, because anyone can join, including general public members, patients, and families who might be pro-MAID. And they've really pushed this agenda that MAID should be suggested to anybody who's potentially eligible, and that you can have death become foreseeable if you forgo life-prolonging treatment, or you say you might intend to do that, or if you choose to say, I'm not going to eat or drink. And so the death being foreseeable, there's no rule that says it's due to a natural progression of the underlying condition. It can be and has been used in Canada from someone saying they're not going to eat and drink, they're not going to have antibiotics if they get an infection. I had a patient who came in with a past history of depression and had a new diagnosis of a heart condition that potentially could have been reversible because no tests were done. This person was in dire distress because they had shortness of breath, in their 50s, and said, I can't live like this. The cardiologist said, I better call the MAID team because I'm going to be accused of blocking access to MAID if someone doesn't come talk to them about an assisted death because they're saying they want to die. This is a very common situation in Canada. And then they called me and said, I'm really distressed. Like, could you help this person understand how we can make them comfortable so that they cannot feel so scared? And while we can talk to them about what the options are for investigating what's going on and potentially treat this reversible condition. So I went down. The person had, within an hour of getting the call, the person had already seen the MAID team, and the husband stopped me at the door and said, we don't want to talk to anyone else today. Why are you here? Explained my role. They said, come back tomorrow. She's too tired. I went back the next day. That person had already been killed and had received euthanasia within 24 hours of coming into the hospital for a potentially reversible condition. Because I was consulted, I reviewed the medical record, and the person was diagnosed with a major depressive episode. And so here you have someone who potentially was feeling unwell in a health crisis, had a past history of depression, probably was having depressive symptoms because of it, wasn't necessarily able to intake all the information to understand what was happening to them and make a clear choice. But then euthanasia was the only quote-unquote care provided in this context. They didn't have investigations for what was going on. No treatment was provided, and they had their life ended. I've had many other examples like that in my own practice, but this is how it replaces usual medical care when it becomes part of healthcare.
Can I just emphasize too that assuming that our condition you just mentioned would have a 6-month or less prognosis, and that it's not one that could be reversed. Maybe it could be treated and managed. There's nothing to prevent that situation from happening in the UK under this bill.
I think that also speaks to prognosis accuracy. We don't have to have treatment. We have a second pathway that started. But even in the first law of reasonably foreseeable natural death, prognostication outside a very short term is kind of not that accurate. It's meant to help people plan, right? I was told I take care of my father, and he has dementia, so he does not have capacity. But I was told 3 years ago, it's the end. It's the end, it's going to be any day now. And my father is still alive and very happy. He's outlived his prognosis from all of his specialists. So I think that absolutely our stories are also relevant. You can kind of say a lot of things are 6 months, and people can end up living years longer than that, even with prognostication efforts, good efforts.
I really wanted to ask you, as I think MPs here are lining up to start pushing this bill through the next phase. One of the talking points that's been raised by Jake Richards, who's an MP that's on the committee, on the Assisted Dying Bill Committee, is that the evidence showed that where assisted dying has been introduced, there's been a renewed focus on palliative care, driving up standards and further investment. Is that something you've seen in Canada?
Yeah, so I think that's something that's commonly said, but in fact there's not robust evidence to show that that's the case. We have had significant impacts on how palliative care can be practiced, and I'm going to come back to that in a second. And then evidence in Canada around funding is very difficult because a lot of funding for palliative care is used to provide MAID. So for example, billing codes for doctors in some provinces, including the province that I recently lived in Ontario, the billing codes to provide MAID, euthanasia-assisted suicide, are the same billing codes used for palliative care. We can't bill those same codes for palliative care, but to provide MAID, you can bill those codes. So there's a lot of work being captured as palliative care that's actually MAID. And then we have some good papers out now that have shown in the academic literature that palliative care professionals are spending more and more of their time dealing with MAID and issues around MAID. And so the amount of time that's available for palliative care specialists like myself to actually focus on doing the good work that we know we can do and can help people has been reduced. Palliative care and MAID have been lumped together as end-of-life care in many places in Canada. And so the operational budgets for palliative care are being used to fund MAID in some places. So our best evidence in Canada is that access to quality palliative care may have increased by about 5% over the past 5 years. That is nowhere near enough to keep up with the exponential increases in palliative care needs that we see as people are living for longer with multimorbidity, and the costs are very significant in the last 1 to 2 years of life, and this provides a much quicker, easier, and frankly the Canadian government has shown a cheaper way to reduce costs at the end of life. So I think it's not fair to say that it has grown substantially in Canada.
And there's a lot of evidence that high symptom burden, so poor palliative care, is leading to MAID. The other thing I would say is that in a Toronto hospital near where I work put out an email asking for more MAID providers. And they suggested that the time, in terms of what Leonie said about the time that palliative care doctors take, it was something like an hour of work to do a MAID assessment, which gives you a sense of the lack of depth of exploring that suffering that is required to do a MAID assessment. The third thing is one of Leonie's confreres, Dave Henderson, who is the Nova Scotia Health Authority, testified in Parliament that he offered to help locally MAID providers do a deeper dive of suffering to see if things could be irreversible or remediated. And they felt that it took too much time. But the last point is that from the MAID Death Review Committee, our first report came out in October, and it was focused on track 2 cases. People are not at the end of life, but people with a lot of suffering, physical and mental health suffering. In fact, a lot of it was mental health suffering. But if you look at terms of what they had access to, so these are all people who died by MAID, less than 50% of them had access to palliative care or disability supports. Less than 10% had access to community solutions. So that kind of shows you with the lie that our chronic care, our palliative care is excellent and we're providing excellent service and MAID is the exception. No, MAID is actually replacing all of these services that we're failing to give people.
Yeah, so we don't like I know the UK has a new law in recent years, right, that says specialist palliative care needs to be funded across all of the NHS, but the reality on the ground and what a law says is very different. But in Canada, we don't even have a law that sees palliative care as an essential service. And so it's actually not required to be funded across the country. And that has not changed since MAID was legalized, but yet MAID is pushed and all the provinces have to provide access to it and fund it. So, if palliative care was going to be improved with this, why isn't palliative care become an essential service and the access to care gone up by more than 5%? So I think you can look at Canada and see that has not actually been the case.
I can always hear the skeptics as listening. And I imagine there may be some people who are listening right now thinking, well, if costs really are very high at the end of life, and maybe quality of life isn't that great, and in a resource-stretched country, someone wants to use their autonomy and make a choice to end their lives, really, who are you to say no?
I think that that's like a very simple construct that people work with because they haven't dealt with the complexities of suffering. And in real life, if you're so desperate, if you have poor pain control, if you don't have enough nursing coming to the house, I don't think that is a great way to die. And then that means that you end your life as an exercise of choice in a terrible way. As Leonie always says, your worst day becomes your last day.
Yeah, and I think, I've seen many examples in my own practice, in my colleagues' practices, that people feel so devalued, demoralized, and not wanted by society. Like, how is that an autonomous choice? We have to first help people be treasured and live well and support them with health and social care, not tell them that they're better off dead. The difficulty with this law, although some people will say, well, it's only it is the people pushing it is like the rich white people. Those aren't the people who are unfairly impacted by this. And I just can't see how you could ever make something like this safe for the people who are most vulnerable in our society, because they're going to, out of desperation, choose a premature death, and in some cases a wrongful death because the law is not even being followed. There's just no safeguards you can put around this to prevent that from happening, and we see that so clearly in Canada.
I would say to Leonie's point that in Oregon, there are some studies that showed that initially it was more privileged people accessing assisted dying, and now after 20 plus years, it's people who are more on government supports who are assisted dying. So this is a public policy that's going to affect everyone. And first adopters do not mean that the policy will be accessed for the same reasons ongoing.
Ramona, I'd like to talk a little bit more about your incredible work. So you're working in Ontario with the Coroner to review MAID deaths and try and identify where things are going wrong and try to build learnings, because we've heard from other people on this podcast that in Canada it's very secretive and defensive, and people don't want to go to prison for murder, so they don't air issues. They don't seem to learn lessons in the way that you'd want. But you're getting to see so many of these cases. Are you seeing issues with coercion by family members or friends or neighbours in this, where it's impossible to say because the assessments that are being done are not going to pick up coercion?
So I do have a non-disclosure agreement about the reports that have not come out yet. I would say that a lot of things that Leonie actually raised in Parliament, a lot of the stories she shared today, have now been validated by things that have finally been published by the coroner. So Leonie testified in 2020 in Parliament that she was seeing cases of patients who had lost capacity where the MAID provider was just kind of going ahead with it. That is basically, if you're not choosing, if it's not free informed choice, that is basically you're being coerced to die. So Leonie is testifying to this in Parliament, and she's chided by parliamentarians because there has been no knowledge of this, no police charges, no college complaints, and they kind of imply that she is being unprofessional and that they need to not really count this testimony. Well, now we know that the chief coroner had already presented findings in 2020 before she spoke in Parliament, but we didn't know because it was all done behind closed doors, that this was a frequent finding, that he had found cases where it didn't seem that the patient had capacity. So a lot of things that Leonie has seen on the ground, yes, I'm seeing some of these cases in a kind of more formal way. And definitely I would say there are many different types of undue influences that affect our freedom. not just being held down and being given MAID or not having capacity. That's very serious what Leonie is talking about. People not having capacity and giving MAID. What is that? That's the opposite of a free choice. That doesn't meet the criteria and it's being killed. But the thing is, if you don't have your financial needs met, so some of the cases that are public that came out in that October report was, a gentleman who had addictions, untreated addictions, and his psychiatrist said, do you know that MAID exists, and because you have a disability you would qualify? That started his MAID journey, and the MAID provider at the end of his journey drove him to the location where he gave him MAID. You can talk about those kind of undue influences, boundary crossing, those suggestions to die that are kind of becoming more pervasive in certain medical cultures, but also in society. Because once you normalize the idea that death can be an answer to suffering, you can start to hear it everywhere. Like, why, have you thought about MAID? Wouldn't MAID, a doctor called me, was very distressed. I've been contacted by lots of doctors in distress since MAID started. And she was saying that at her hospital, sometimes she is just approaching the patient. She's a palliative care doctor. And as she's approaching, the patient will say, if you offer me MAID today, you'll be the fourth person who started with that. Like, I'm here for care. And the question is, in my mind, that is undue influence. You constantly suggest to someone that their life is not worth living, that maybe they're going to be better off dead. What are you inspiring? You're inspiring terrible fear. You're encouraging fear and you are decreasing hope. And I think that is extremely concerning. So yes, a lot of the cases that we talked about and so the ones that are published, there was a whole case report that had talked about many different issues, but consistently people who had untreated mental health issues. So basically, they felt really down. Their mental illness was influencing their choices. That, in my sense, is also undue influence, right? No one is taking care of all these things to make it really free. And I think that that's very concerning.
Just to return to that question of couples, so what we're seeing here is that there's this historical legacy of people who are quite big in the euthanasia movement, where the man who's much older there's basically a suicide pact, and it's quite often his diagnosis that leads to that. And certainly we've had people go to Dignitas where it's again the man with a terminal diagnosis and the wife has followed him. I'm really disturbed to hear that seems to be something that's emerging almost as a romantic story with you.
Yeah, so I do believe that the coroner released in his May report of last year that there is a large amount of women seeking medical assistance in dying in track 2, so they don't actually have a terminal illness. And a lot of them are widows, women whose husbands have died. And so I'm very concerned about that. Yes, about due euthanasia. I have heard cases of where it seems that one person is really kind of pushing the other person. And the coroner, I believed, has done teaching with MAID providers about, trying to make sure that the assessments are separate, trying to make sure that there's no coercion. But how do you really know? I used to do care in the home, as I said, and it would take me many months to realize. I had this one story, very sad, of a lady who was losing weight and wanting to die. Thankfully, this was before MAID, but we were wondering, did she have cancer? It turned out that her son, who helpfully moved in to help her, was not feeding her and stealing her money. But at that time, it took us several months to figure that out. So how do you actually know what happens with a couple? It can be very difficult to know that. And especially when the assessments are so quick, so short, they're not over long periods of time, despite what they say. If you look at the actual evidence about the times for these assessments, they're not deep dives of suffering. They're non-long accompaniments of patients. And so I'm very, very concerned about that kind of influence to die.
And it's often MAID assessors who don't know the patient, right? And so if you don't know a person, they're not going to disclose how they've been in an abusive relationship or how they're being coerced by a partner or a relative, right? It's very difficult for us to detect. And so the couple ones make me very concerned that it's not a free choice, and there's definite expectation that they would kind of go along with it. It's very worrying.
Going back to what you said earlier about the MAID assessments just being an hour, that was the evidence. And Australia is the model for the UK bill, for the Westminster bill. And the South Australian doctor who does that there, she said she will spend up to an hour with patients, and she will sometimes send family members out of the room so that there's less risk of coercion. But obviously, they're sitting in the next room while she spends an hour with this person. You said, Ramona, it took you months to assess that someone was in this kind of really desperate abusive relationship.
Right. Sometimes it takes me years before a patient will tell me that actually their partner is part of the huge part of their mental health suffering, right? They often come together, they present together, they join a practice together. It takes a lot of trust to see. The Health Canada report also showed that there's a higher propensity of women choosing track 2. And that is concerning because women have the risk of intimate partner violence, the lack of care. Women tend to also get poorer medical care. There's a lot of issues here that threaten women.
There's been an amendment put forward here that would require physicians go through training, which is a step in the right direction. But at the same time, even with that training, you're saying it takes months to start to detect that, to build enough rapport with someone that they would feel that they trust you enough to confide in you, or that you would be able to catch some of those subtle signs. So that's very, very important for policymakers here to hear.
I would say in medicine, the training that we're able to get is very inadequate to detect both from an assessment of capacity as well as an assessment of coercion. It's even the best training is not good, and it's very difficult for us to know that. And then especially when you don't even know these people as a MAID assessor, it's because there's not that many doctors who want to do it. They're often sometimes doing it over the phone. You can't even see the person's face or what's going on for that person. It's very common now that assessments are done virtual with someone you've never met before. So yeah, very problematic.
And the other thing I would say is that suicidality, as Leonie said, so women have higher rates of suicidality. Most of them recover with care and do not reattempt. But MAID is 100% lethal. And so you have a lot of these risks for suicide tracking exactly onto the risks of MAID, and you have 100% completion. Well, basically, we're failing these women who needed care and needed suicide prevention.
That there's no safeguard in the bill proposed to Parliament that requires a mental health assessment if the clinician suspects that a person's judgment is impaired due to a mental disorder. The only safeguard is around mental capacity. There's nothing around mental health.
You know what? Like when people get a cancer diagnosis, when people get an end-of-life diagnosis, what happens? People get very depressed. They get scared. That is the time that they actually need psychological support. They need therapy, and they need people like Leonie. They need palliative care. And so the thing is, if you're deprived of all of those things, well, won't you be more influenced to choose death?
Well, I had a case of a man who had an early cancer diagnosis, came in for a palliative care assessment for pain. When he came into the clinic, he was like actively suicidal. He had like a date, a plan, access to a weapon, previous attempts, military history, like all of when you're training in medicine, all of the red flags that go, okay, we actually need to take care of this person because they're a danger to themselves. And in those contexts, in Canada, I'm sure it's similar in the UK, we would admit someone to hospital even against their will if they're not willing to come in so that they don't commit suicide. In that case, I called the psychiatry team and said, I have this actively suicidal patient in my clinic. Could you come see him urgently? And they came in to do their assessment. I went in to see another patient. When I came out, that man had already been sent away with the MAID phone number. So the psychiatrist said, and in their notes, and told me, because I called them, like, what's happened? Well, they have a cancer diagnosis, so they're eligible for MAID and they don't have to do this themselves. So instead of doing suicide prevention and taking care of this man who had an active, emergent mental health issue, he was given the MAID phone number and said that they could assist his suicide. I mean, that's that's not the only case, that we've seen, that even the woman I described, she had an active depressive episode which was clouding her ability to understand what was happening to her in her current health issue to make and be able to make a clear choice. It's crazy. That's crazy.
I think that it's very important to say, because I don't think we covered it in this podcast, and related to all this is that there are a lot of suffering families who knew that their family member was depressed and are totally devastated and cannot live with the fact that their family member got MAID quickly. There's there's several court cases now. So all of these court cases, all of these families with no answers. MAID is not just about care and compassion. You will have devastated families. I have patients that text me on the anniversary of their family's MAID death because they are struggling with the fact, like the PTSD that it's caused. There's just all these different levels of pain besides the wrongful death that will affect society. Because suicidality increases suicidality in those around them. Completed suicides increase the risk of self-harm. So what does this do to our society? I think it's just very important to put that out there.
Just again, I'll say that the stories you just described, if the person has a condition that could result in their death within 6 months, none of these would be outside of the scope of the bill being considered. I just have to really, because I think so often people hear the stories and they dismiss them.
It's still harmful to you, and it will still leave trauma if your family member was still close to death but chose it because they were depressed, right? Like that's some of the stories are. And people are very dismissive here, just like you're saying in the UK, they're like, well, they were close to death anyways.
Yeah.
No, that you're basically saying their life didn't matter.
Well, on that note, I think we all agree that their lives do matter. Part of why Fiona and I have put this podcast together is to help get these messages not just to people in the public, but also to MPs. So I wonder if you had one message for MPs who are considering this bill from your experience in Canada.
I would say that this is a public policy that affects everybody. That even though we think that it's an act of compassion, I think that the number of victims is high and it causes devastation in many different ways to families, to society, and to people who are wrongfully had their lives ended, and that there is no safeguards that you can enact that will protect all people. And do not be surprised as safeguards quickly fall away, because even if you have some safeguards, you have practice patterns, and those practice patterns can find ways to circumvent the law. And once you open up death as compassion, you have a lot of MAID practitioners or clinicians who think they're doing something compassionate. They don't even realize that their bias is leading to wrongful deaths. And so they'll find ways to circumvent those safeguards, as we've seen in Canada, even though they were flimsy and fallen away, even the ones that existed. And there's no safe way to enact this.
Yeah, I think you said it so well, Ramona. I think that's the main key message for me, is that there's absolutely no way to make this safe, and there's no safeguard that can be put in place that won't be eroded over time, and the law will be expanded over time because it becomes seen as a right, and then you're discriminating against different prognoses, different types of conditions, different people, and so it will absolutely expand over time, as it's done in every jurisdiction.
When in fact it's actually discrimination against the patients, right? Because they're actually being deprived their right to life because they're lacking care.
Yeah, and it completely changes the practice of medicine. It has completely changed palliative care practice. It has completely changed the role of the physician as focusing on health and healing and helping people live well while they face the challenges of serious illness. And I think first and foremost, that's our duty as a society, is to take care of one another.
Hi, it's Fiona. Chelsea and I were so keen that we start to hear some really detailed debate on what assisted dying could look like here in the UK for women. We do not have big money funding, so if you'd like to support us, you can go over to our Substack and subscribe there, or you can donate to The Other Half on our website, theotherhalf.uk/donate. So grateful for this, and so grateful for you listening, though. Thank you.